Welcome to our video on transient urinary incontinence. Let's get started. To understand the different pathologies of this lecture, we need to review some basic concepts. As you know, the role of the bladder is to accumulate and release urine. Now, urinary incontinence occurs when this function is impaired in really any way. This could mean the unwanted release of urine, the excessive storage of urine, or anything in between. And there are actually a variety of mechanisms that can lead to those alterations. Before we get to those, let's illustrate the normal anatomy of the urinary system. Here we see a sagittal view of the female pelvis that we'll use to illustrate the components that are necessary to maintaining urinary continence. And we refer back to this image in our different lectures on the various types of incontinence. Okay, so notice the bladder and the urethra and the vagina and the pelvic floor muscles. The pelvic floor and the anterior vaginal wall will act as this hammock, which stabilize the urethra so that the urine doesn't leak. And this is especially important in preventing urine leakage when intra-abdominal pressure is high, for example, when coughing or sneezing. And the urethral sphincter is located at the neck of the bladder where the urethra begins, and it provides circumferential resistance to urine leakage. The detrusor muscle is made of smooth muscle, and it lines the wall of the bladder. And when it contracts, then urine is released. And the coordination of those functions is controlled by several nerves. And naturally, any malfunction of any of those structures can lead to incontinence. So for the remainder of this video, we're going to talk about transient incontinence, with a special focus on urinary tract infections, as well as genitourinary syndrome associated with menopause and functional incontinence. So let's start by illustrating this helpful mnemonic for remembering the different causes of transient incontinence. So here we see the mnemonic diapers, and we'll actually use this to help you remember the 8 common causes of transient incontinence. Now, before jumping into more chronic pathologies, it's helpful to consider those that are easily reversed. Start with those, and then we'll talk about chronic. So first, D is for delirium, and that often shows up as an altered mental status patient, or a hospitalized patient, or an elderly person. I is for infection, specifically the urinary tract. A is for atrophic urethritis and vaginitis, and that's associated with menopause. And we'll discuss that menopause idea as it relates to transient incontinence on a future slide. And notice that diapers is spelled wrong here. There's 2 P's. The first P refers to pharmaceuticals, and that could be extended really to anything that one ingests that eventually causes urinary incontinence. So some examples of medications that can cause transient incontinence include alpha blockers, such as prazosin, or even diuretics like furosemide. Now the second P is for a psychological diagnosis. And as an example, there's depression, and that can cause transient incontinence. Now, E is for excessive urine output. That can occur in a patient with diabetes mellitus because of that osmotic diuresis, or it could even happen in a patient with congestive heart failure. R is for restricted mobility, and that's common in post-surgical patients. They just can't move or can't get out. And this would fall under the umbrella of functional incontinence. And functional incontinence occurs in a patient that has a working urinary system, but they urinate themselves anyways. They experience incontinence. For example, they just can't get to the bathroom. They're super old and they're not very mobile. And S is for stool impaction. So constipation, basically. So in the next few slides, we're going to explore a few high-yield causes of transient incontinence in greater detail. So let's start with UTIs. The typical symptoms of a urinary tract infection may include frequency, urgency, dysuria, and hematuria. Urinary frequency is when patients feel the need to go to the bathroom more often than normal, where urgency is when the patient feels a sudden urge to urinate. And sometimes this has that panicked feeling where they think, oh, I'm going to wet myself. I've got to get to the bathroom. Dysuria is painful urination, and hematuria is when there's blood in the urine. Now, most important for this lecture, know that all patients with urinary incontinence should have a urinalysis performed. And on that urinalysis, a positive leukocyte esterase on urine dipstick, or greater than or equal to 10 leukocytes per microliter under the microscope, would be highly suggestive of a urinary tract infection. Now, leukocyte esterase really indicates that there's inflammation, not specifically an infection, but it does raise your suspicion of an infection when you think that the patient does have one. So how do you treat a urinary tract infection? Well, antibiotics are actually the treatment of choice. The first line would be nitrofurantoin, trimethoprim sulfamethoxazole or Bactrim, fosfomycin, and pivmecillinam. Now, the decision of which to use is based on physician preference and regional factors. And this topic is reviewed in much greater detail in our medicine lecture entitled Infections of the Genitourinary Tract. Now let's talk about the genitourinary syndrome of menopause. Genitourinary syndrome of menopause is a diagnosis worth considering in women with low levels of estrogen, such as those that are menopausal. And here's why it's so relevant. So these decreased hormone levels can lead to atrophy of the urogenital tissues, and that can manifest in a wide variety of ways. So patients can experience urinary symptoms like urgency incontinence or recurrent UTIs. So it's helpful to understand that the urethra and the bladder trigon, they're estrogen sensitive. So those tissues rely on estrogen. So in the absence of estrogen, patients experience urgency. And the recurrent UTIs that some women experience actually arise from the altered vaginal pH that occurs in postmenopause. So those are the urinary symptoms. Vaginal symptoms include dryness, pruritus, dyspareunia, or pain with intercourse, and even bleeding. Again, all of this is a result of low estrogen. So let's show a visual representation to drive this home. Here we see an artist's depiction of normal vaginal mucosa on the left and postmenopausal vaginal mucosa on the right. And notice that significant atrophy. And this occurs because of the low estrogen. And that's a reason for many of the symptoms that we've just described. Now, the physical exam in these patients shows decreased vaginal rugae, thinned vulvar epithelium, reduced elasticity, and even petechiae. And the petechiae are just small areas of bleeding underneath the epithelium. Now, as far as treating these patients, you want to start with vaginal lubricants, those that are not hormone related, and then you can consider topical estrogen if the lubricants don't work. Let's finish our discussion of transient incontinence by covering functional incontinence. So functional incontinence is defined as the inability to properly void despite the presence of intact urinary system functions. Most commonly, this is the result of physical or psychological impairment, such as a patient who has restricted mobility following a leg operation, or a person suffering from dementia. In making this diagnosis, a good history and situational understanding of the patient are paramount. Now, for example, a question vignette may be designed to have you thinking that the patient is suffering from a neurological impairment, like the nerves that act on the bladder and urinary system itself is impaired, when in fact, the patient's bladder function is completely intact. Now, once you've made a diagnosis, the treatment will center on reversing the underlying condition where possible. For example, you may work on helping a post-surgical patient move better to help them get to the bathroom more quickly, or decrease the medication load on like an overly sedated patient that can't really psychologically get to the bathroom or notice it on time. Now, in some cases, such as those with dementia, then supportive care is really all that can be offered because you can't reverse dementia. And here's an overview table of urinary incontinence and those etiologies and their key features. Now let's wrap up with a question. An 82-year-old female resident of a long-term care facility wakes up confused and disoriented. She wet herself overnight and has a temperature of 38.1 degrees Celsius. What is the best next step in management? Okay, so this is a fairly classic presentation for delirium in the setting of some sort of infection. We have an elderly resident of a long-term care facility who wakes up confused and disoriented, got a fever, and the clue to her specific diagnosis is that she wet herself overnight. Now, both delirium and UTIs are possible causes of that finding. But given both her fever and the fact that infection is a common cause of delirium in the elderly, then the next best step in management would be to order urinalysis, because you want to assess for a possible UTI. Now, because she's at a long-term care facility, it's worth getting a urine culture as well. Now, one important thing to note here is that lower urinary tract infections will not always cause a fever, so be methodical in your approach to these patients. In other words, don't just assume that if they're afebrile, that they don't have a UTI. And that concludes this section.